A very big hello to all my dear students. Welcome to the T2O series, favorite channel, You and I with Dr. Ruchi. So today we are going to take some FMG recall questions of the recent exam, that is July 2024. Let's discuss this. Okay, so question number one is, okay, before I start, of course, it is going to be very crisp and quick. So please pay attention. So what is seen in blunt trauma? What type of cataract? I think it's a one-liner, very simple question. We all know blunt trauma we have learned is rosette-shaped cataract. Where do you get Christmas tree cataract? Again, we know Christmas tree, it is myotonic dystrophy. Snowflake cataract, it is diabetes mellitus. Sunflower cataract, it is calcos. I think this was very, very simple. So here our answer is rosette shape. Let's have a look. So this is your rosette shape cataract that we are talking about, right? Another question on rosette shape is that it starts from which part of the lens? You will say it starts from posterior cortex. It starts from posterior cortex, right? Okay. Another question for diabetes, which I remember, is which type of diabetes will most commonly have this snowflake? What is the other name? That is snowstorm cataract. You're going to say it is type 1 diabetes. Type 1 diabetes. Right. Okay. Let's come to the next. Have a look. What is this? This is what is sunflower cataract. Right? In calcosis. Calcosis is what? Copper inside the eye can be seen due to copper containing foreign body or Wilson's disease, right? What is this? This is your Christmas tree cataract that we just talked about. Christmas tree is a feature of myotonic dystrophy. Okay, and these are the snowflake cataract, right? So sunflower, Christmas tree, snowflake. Okay, we come to the next question. Any other thing we want to discuss here before I go to the next question? Um, yeah, so KF ring is very important question here. Along with in calcosis or Wilson's disease, what else you get is case of Fleischer ring. I hope you remember this. It's again a copper deposition in the Descemet's membrane. We'll not forget this. Any other point in KF ring? I think I've discussed this before also with you all, that it starts from superior and inferior quadrant. Then it becomes a circle. That was one point. Secondly, all patients with neurological complications will have KF ring, but not all patients of hepatic involvement, right? So this was also once asked in your INICT exam. So we'll remember this. Okay, so KF ring is asked in every type of exam. Okay, so these are some additional questions. Yeah, so another question is, let me ask this as well. If you remember in diabetes, why do you get a cataract? I hope you know it's due to sorbitol accumulation in the lens, which is very hyperosmotic, leading to this type of cataract. So these are the questions around this these options. Then we come to next question. The next question that was asked was acute sudden painful diminution of vision with mid-dilated pupil. It's so simple. It's sudden and painful diminution of vision. So there is pain, there is diminution of vision, and there is a mid-dilated pupil. Of course, we are talking about acute congestive glaucoma, right? Yeah, or angle closure glaucoma. Acute congestive will become even more painful with very high pressures. You remember? So acute congestive is a stage of angle closure glaucoma. So here what we are going to answer is angle closure glaucoma. Optic neuritis may or may not be associated with pain, but again, mid-dilated. If you look at the sudden painful diminution with mid-dilated, it goes more in favor of angle closure than optic, right? Because that is one important thing you have to remember. Optic neuritis is nothing but optic nerve disease. So what will be the pupil? Pupil will show here instead not mid-dilated. It is going to show RAPD, that is a relative afferent pupillary defect. This is the first sign of optic nerve disease, right? We'll remember as first sign of optic nerve disease. Okay, so this we know, that is clear, right? Okay. CSR again, of course, will not fit into this description. It's absolutely painless condition. We know what is CSR. It's a shallow retinal detachment at the fovea which is happening in young males, generally idiopathic and generally self-limiting. Only when it is chronic that it will not resolve by itself, otherwise it is self-limiting. Yes. And of course, cataract again will not be associated with this presentation. So here you see a patient, you are seeing, what are the findings here? This is your corneal edema. It's a cornea is a little hazy, I can see. I can see a vertically oval mid-dilated pupil, and I can see some redness here. So what is this? We are talking about acute congestive glaucoma. So mid-dilated, vertically oval mid-dilated pupil. So maximum angle closure occurs in a mid-dilated position of the pupil. Okay, we come to the next. Oil droplet I don't know whether this question was asked or not, but since some people are saying it was asked, so oil droplet, of course, is galactosemia. Another question here is that this is one of the reversible cataract. If they ask you, it's always galactosemia. This is one additional question that you will remember, right? Okay, so this is an oil droplet cataract. This is what is oil droplet cataract. It looks like an oil drop. Okay. What are the other oils that you have studied with me? I think again in my channel also I have discussed this again and again. So if oil droplet cataract, we also know oil droplet reflex, which looks almost like this. But yes, oil droplet reflex when I'm talking about keratoconus. How do you see that? You don't see on the slit lamp. We are talking about distant direct ophthalmoscopy. So in distant direct ophthalmoscopy, which is done at 25 centimeters, this is again asked in the exam. What you see is this type of oil droplet reflex. What is the other term? Oil globule reflex. So these are the three oils you should keep in mind all the time. Every time I discuss all the oils so that you can remember nicely. So oil droplet cataract, oil droplet reflex, and oil globule reflex क्या होता है? Oil globule reflex is seen in anterior lenticonus. Again, this is a slit lamp finding. When you look at the eye in retroillumination. What is retroillumination? When the line of sight and the source of illumination are both in the same axis. So how do I know I'm seeing a retroillumination? I'll see the background fundus glow. Then it is a view is retroillumination. We come to the next question. Which of the local anesthesia is used in cataract surgery? So which local anesthesia is used? Which one are you going to answer? Of course, it is lignocaine. We can lignocaine or lidocaine, or xylocaine, it's all the same. Okay, so lignocaine or lidocaine, whatever. Right? Bupivacaine helps to sustain that effect, and generally 0.75% is given. And we all know Paracaine can be given for topical anesthesia. Don't forget, when you're talking about the anesthesia, I hope you should know where do you give a peribulbar and where do you give a retrobulbar. See, I'm making life very simple. This is optic disc, this is optic nerve, right? So, and these are the muscles, right? Attached, suppose, from this. If these are the muscles attached, when I am saying peribulbar, it is outside this muscle cone. Okay, so if this is the muscle cone, these are the muscles attached. We are saying anything which is outside, this is, if the injection is given here, so this is outside the muscle cone, this is peribulbar. Okay, and when we are giving it inside, this is what is, so when you're giving it from here only you'll give, and if you're giving it inside, it is what is retrobulbar. Okay? So retrobulbar, can you understand? If you're giving inside the muscle cone, naturally there is always high chance of damaging the optic nerve. You have to be very, very careful in a retrobulbar injection. So the length of the needle is ½ inch longer than for the peribulbar. 1 inch, this is 1.5 inch. Okay? And these are the anesthetics which we use. Is it okay? So I've just indicated muscle insertions. I'm not making all the, giving you an idea. Okay, then we talk about the next question is curtain falling sign is seen in. So we all know what is curtain falling sign. It is mainly when there is, okay, let's have a look rather than describing. So when the visual field or the vision is going, can you see this up to here? So this all vision is decreasing like this, as if a curtain is falling in front of my eye from the periphery. So this is typical of rhegmatogenous. This is what is rhegmatogenous retinal detachment. So we learn this is typical of rhegmatogenous retinal. And I hope you all know another question. Rhegmatogenous is the most common RD. What you're looking here, this is a giant tear here. I can see this is a demarcation line almost made where this is gray reflex of the color. This is your gray reflex, which is showing you the detached retina. And this looks like a more like a demarcation line, right? Demarcation. Demarcation line will be generally seen in older RDs where where you can see the separation so clearly between the attached and the detached, right? So this is here what we are going to answer. We will be answering retinal detachment. Okay, come to the next one. Cherry red spot is seen in. Everybody knows what is cherry red spot. It has been asked again and again in all exams, right? So we are talking about this type of picture where this looks like a cherry here. This is what is cherry red spot, right? At the macular area. Okay, so when you say this cherry red spot and the rest of the area is edematous. First of all, why are you getting this rest of the area edematous? Why is there no edema at the very center? Because the very center, not all layers are present, isn't it? So if you are going back to the structure of your retina, you will realize that this fovea and foveola have only 5 layers or 6. So the layers where the blood vessels are there are absent here. That is why there is no edema there. So why it is showing you red? That is due to the choroidal vasculature. You see red. That is what is cherry red spot. Did you understand? Edema will be where is nothing due to leakage from the blood vessels. So do you not remember this anatomy where you have avascular zone, foveal avascular zone? So in avascular zone, there is no blood vessel, no edema. So the background choroid is shining red. I think now it's simple. Now you understand. So the number of layers also in the very center of the retina are not, normally it is 10 layers, right? But in the fovea and foveola is only 5 layers and fovea is 6 layers of retina. This is the reason no edema, no leakage here. And therefore the background choroid vasculature is looking red. Anyway, we come to the cherry red spot. Is what are the causes? I have taught you so many times. We will divide it into 3 logically and very simple. One is Berlin's edema. इसको और क्या बुलाते हो? Commotio retini. Berlin's edema is also called commotio retini. Okay, that is blunt trauma. So you can get edema everywhere except at the center. Secondly, the same situation for CRAO. Again, arterial occlusion. You can get edema everywhere except the center. Whereas the third, we can learn it as depositions, and in depositions, we learn all the gangliosidosis GM1, GM2, that is Tay-Sachs disease, है ना? Then Niemann-Pick disease. What else? Even Gaucher's, right? So Gaucher's may type 2 you can get a cherry red spot. What else? Standoff, Cialosis. All these cases this is where you can get cherry red spot. Okay, so if you want to really know the causes for the deposition, we can note it down. The important ones are Tay-Sachs, Niemann-Pick, okay, then Gaucher's type 2 disease, then you come to GM1, gangliosidosis as well, which is again which one? It is type 2, right? Then what else? Then Sandoff's disease, Cialosis, and so on. Right? So we'll remember, so we are going to remember all this as the cause of cherry red spot. Okay, so what will the answer here? Cherry red spot is seen in. Now, if Gaucher's and Tay-Sachs both are given, definitely because Gaucher only one type has cherry red spot, I would prefer to answer Tay-Sachs. Okay? Okay. We next talk about is which nerve is involved in the lateral rectus palsy. Remembers this? LR6-SO4. So LR6-SO4, lateral rectus, 6th nerve, superior oblique, 4th nerve. And rest of the muscles, we all know rest of the muscles are supplied by 3rd nerve. Right? What are the rest of the muscles? Superior rectus, medial rectus, inferior oblique. Right? Superior rectus will be supplied by the superior division of 3rd nerve and rest will be supplied by inferior division of 3rd nerve. Superior division also supplies the levator palpebral superior. So this is the way we learn and therefore the answer is this. So have a look. This is a child with a convergent squint, lateral rectus not working, this is your sixth nerve palsy. Okay, with convergent squint, right? So left eye convergent squint, why it is converging? Because the lateral rectus is not working. So convergent squint. We come to the next question. Leg of thalmos is from which nerve defect? So inability to close the eye is called leg of thalmos. As you know, look at this one. The eye is not being able to close properly. This is the case of leg of thalmos. And of course, the muscle responsible for closing your eyes, orbicularis oculi. And orbicularis oculi is supplied by, it is supplied by facial nerve, that is seventh nerve. So here the answer becomes seventh. And what is the main risk if the eye is not able to close? It will lead to corneal keratopathy, which is called exposure keratopathy, right? So corneal pathology, that is exposure keratopathy. So we may need to do a tarsography to join the lids to avoid this corneal damage, or we may even use gold weights on the upper lid so that the eye closes, right? So that was about leg of thalmos. Next question is define blindness according to WHO. So according to WHO, we all know it is best corrected. BCVA क्या है? Best corrected visual acuity of less than 3/60 in the better eye, we will always say. When you say best corrected visual acuity, it means after the specs correction in the better eye, right? Of less than 3/60, or also learn with me visual field of less than 10 days. NPCB since 2017 has also shifted to the same criteria of less than 3/60. Only thing difference is here we will learn best available visual acuity of less than 3/60 in the better eye. Okay? Or visual field of less than 10 degrees. This is same. Okay, one more question. What is the prevalence of blindness at present? You will answer in India. The prevalence of blindness is 0.3%, 36%. Chalo, we come to the next question. A patient with ATT presents with sudden diminution of vision. Which drug is involved? Any ATT, which drug is involved? Can you understand here that we are talking about toxic amblyopia? पढ़ाया था ना? So toxic amblyopia means toxic amblyopia. Amblyopia. What is toxic amblyopia? Amblyopia is partial loss of vision. Toxic matlab due to drugs, right? So due to the drugs, there is a partial loss of vision. What are the drugs involved? Of course, it is ethambutol. Anything else you want to learn with me? Yes, tobacco. Ethambutol is the ATT drug, which is most important to learn. Then chloroquine, right? Anything else? Yes, ethyl alcohol, methyl alcohol. All these drugs will affect the optic nerve and can lead to optic neuritis, right? So neuropathy. Even isoniazid is also known to cause optic neuritis. So here isoniazid, ethambutol, both are. You always prefer ethambutol. Okay, isoniazid is also known to cause. Right, all of you. So here we answer ethambutol. And what is the, whenever there is going to be an optic nerve involvement, what is the color, which color blindness, and what is the color affected? Red, green. Okay, so here it will be red, green. In optic nerve disease, it is always the red, green. Okay, except only one condition where the red, green disc chromatopsia decrease color. I have taught you, na, in any optic nerve disease, they decrease color, there is disc chromatopsia. So generally, it is red, green, except glaucoma, where it is not affected. Anyway, we come to vitamin A deficiency. Of course, we know we are talking about Bitot spot. I don't think we need any explanation here. So this is the Bitot spot that you see in xerophthalmia. A very quick revision of WHO grading of xerophthalmia. Xerophthalmia can be XN. XN means night blindness, that is nyctalopia, right? Then comes your X1 is divided into A and B. A is your conjunctival drying or cirrhosis, and B is your Bitot spot, right? Then we talk about is X2. X2 will be your corneal cirrhosis. After X2, then We have X3, which is keratomalacia. What is keratomalacia? Keratomalacia is melting of cornea, and when it is involving less than one third, this is your A, and if it is more than one third, it is your B. 3B. Then X3B. After this, XS is corneal scarring, right? And XF is corneal, that is xerophthalmic fundus. You won't forget this. So this WHO grading is important. Another thing they can ask you is treatment. What is the treatment of vitamin A deficiency? If your patient is more than 1 year, we give injectable vitamin A 1 lakh international unit on 0, 1 and 14 days. Will not forget this. And if the child is less than 1 year, we half the dose. And of course, if you are giving oral, you double the dose, right? And everybody knows what is Stocker's line. So at the head of the pterygium, this iron deposition that occurs is what is called Stocker's line. Hope you remember this. This is what is Stocker's line. Okay. We come to the next one, sudden painless loss of vision with no fundal glow and no history of trauma. So there may not be a history of trauma. There are many other causes of the vitreous hemorrhage, but no fundal glow very strongly suggests it's a vitreous hemorrhage, right? You will get fundal glow in all these three options shown here, right? So we will answer vitreous. So you should have a look at this is what is the hemorrhage inside the vitreous. This is your vitreous. Vitreous hemorrhage in two ways that you should know where you should connect your mind to. One is of course in diabetes or any cause of retinitis proliferans that I've taught you, where any vascular retinal pathology can lead to or complicate into vitreous hemorrhage, right? What is the second that should come into your mind? They can ask you is Eales disease. Patient of Eales disease. Eales disease, what did you learn? Eales disease was periflavitis retini. So patient of Eales disease are going to present, when you talk about patients of Eales disease, can present with recurrent vitreous. It's a recall. I'm not going to go too much in detail into Eales and all, but keep this in mind because at your level, these are the two places where vitreous hemorrhage is going to be asked. Trauma, any vascular retinal pathology, or Eales disease, that is inflammation. Okay. Then we come to normal flora of the conjunctiva. Conjunctiva, cornea, normal flora is always staph or of epidermidis. So you have to answer staph. Staph epidermidis you also learn, and that is why I see it is the most common cause of acute onset. Where else you learn? Most common cause of acute onset endophthalmitis. Most common etiology क्या है? It is staph epidermidis. Another thing that you have learned about staph epidermidis is it is the most common infection after keratoplasty. Remember the keratoplasty. So remember all this. Okay? Okay. We come to the next. Different refractive powers in two eyes. Okay. +5 in one eye and +1 in another. What is the diagnosis? See, if vision was given, then our diagnosis would be amblyopia. So some students are saying that the vision was given. So if there is a vision difference, then of course we can see it's an anisometropic amblyopia, right? If the vision is not given and just is, then it is only anisometropic. Anisometropia is not given, then we will answer refractive errors. So it all depends. So because you all are saying vision is given, so I will just note down here if the vision was mentioned, then the answer of this question will become anisometric. You all remember what is anisometric? No? Difference of refractive power between two eyes of more than 2.5 done. 2.5 done. Okay. Then one figure given and they had asked you about the what is the correct refractive error and it is corrected or not. So we know we could not land up into the actual question, but we can just have a look at this. Very simple. It's not very difficult here. That if what is myopia, where the focusing is in front of the retina, and we use a concave lens. Now the focusing is on the retina. Okay. And then you can even look here for the hypermetropia, where the focusing parallel focus behind the retina. When I use a convex lens, it goes on the retina. Okay, not difficult. Talking about this is a typical cornea. When the light is focused, there is a single focal point. But if there are more than one focal point, this is what is astigmatism. So this concept should be clear. I think there was another question on this image, that is your As you know, this is nothing but a simple wire speculum, which we use in any eye procedure and surgery. Whether it is a big surgery or a small, you always have, which helps to open the eyes, right? So wire speculum. And this was asked, some people are saying, okay, there was a retractor. So this one is a Desmarais retractor. And as you know, Desmarais retractor will help to pull the lid up, to retract the lid, to find some foreign body for double evasion of the ray. So this is what is Desmarais retractor. Okay, so these are some plus minus whether it was asked or not, but I've included it if it was asked. There was another question on, I was told on flectanular conjunctivitis. So this is a case of flectanular conjunctivitis. You can see this phlecten here, right? I can see the phlecten here and I can see this congestion here. So this is your flectanular conjunctivitis. It is going to be seen mainly in the low socioeconomic setup where the hygiene is less, okay? Another thing is most common is etiology. It's an endogenous allergy. Let's quickly revise it. And the most common etiology here would be your staph aureus. And second most, of course, if this is not given, then the next is tuberculosis. Right? We all remember this? Yeah. And of course, what else? It's a type 4 hypersensitivity reaction. This is another exam question. And treatment would be you have to give steroid. Another question can be that this phlecten can lead to formation of an ulcer, which is called fascicular ulcer. This is another exam question, fascicular ulcer. And this fascicular can later turn into a ring ulcer. Later turn into a ring ulcer. So these are some points about flectanular. I think these were the questions. I hope you enjoyed the discussion. So keep studying. Happy reading to all of you. Stay blessed. Thank you.